pinpoint and direct these sound waves, not radio waves, sound waves, high frequency, and then shatter the rock, and then wait until you pass them. Okay. And if that didn't work, then of course you either had to try a basket extraction, or if that didn't work, then you'd have to actually go in and do it. Open them up and go into the wherever the kidney stone was, and they can be.
Sounds like it's major
That's major.
surgery.
Yeah, that's major. Litho, you could probably go home the next day. Okay, but yeah, slicing you open and going into your kidneys—that's a big deal. All right, lithotripsy. Anything? Oh, let's talk about the bladder just a little bit, because there's. All right, we know that we have this urinary bladder. Okay, and it kind of comes down like that. And unfortunately for me and you, at the top of that we have a prostate gland.
Well, I used to.
Oh, okay, yeah. And you have this area in the bladder called the trigone, but you have where the ureters will come into the bladder, these inputs, if you will, from the ureters, and again, they extend off the renal pelvis. Okay. Most of the bladder is a muscle called the detrusor muscle. I think it's 2 S's. I'm not sure. Let's see, they tell us. Okay, and you can see. And the process by which we remove urine is called, well, it's not really a triangle like that, I guess. If we look at that little picture there, we have this sort of triangle like that. But the process of removing urine from the body is called micturition. It's also called urination. And it's also called voiding. Either of those will suffice to describe how this urine is removed from the body. Okay, and then passes from the neck into the urethra, of which you only have one. You have 2 ureters, and people get those confused, so don't. 2 ureters, 1 urethra. Now in males, we have this prostate gland up there at the top, which is involved in contributing fluid to the seminal fluid. And a common problem in males, particularly American men, is BPH, which stands for benign prostatic hypertrophy.
Other countries are not as
Asian, for some reason, Asians don't seem to have, people in Asia don't seem to have as high an incidence of BPH as we do. And I'm not sure if they know why. Okay, but American men, I think it's 1 in 3, or maybe 1 in 4, will experience some problem with the prostate throughout the course of their lifetime. Either BPH or prostatic cancer. Okay, they recommend that you have a prostate exam. The first one usually right around age 50, and then every 10 years or so, or 8 to 10 years thereafter. Okay, I'm due, and I'm going to do it, as well as the colonoscopy. I had both of these done at age 50, and I'm a year or so behind, but I'll get to it when I mention that. And I try to impress these young teenagers about, as they age, you're going to want to get that checked out. And they go, oh, hell no, I'm not going to let anybody do that. I said, well, the alternative is not so cool. So you might want to do that. All right. The average, it's only 1 S for detrusor, I'm sorry. You start to feel a little uncomfortable, and it'll vary with different people, when about a half a liter starts to collect in your bladder. And then you have this urethra, and you have an internal and an external urethral sphincter muscle, a circular muscle, okay? Now the internal, you cannot control under involuntary control, more like smooth muscle. The external urethral sphincter is more like skeletal muscle, because you and I both know we can control that. You can start a stream and then stop it if you want. But the internal is not under voluntary control. Okay, so the take-home message there, go to the bathroom before you get on the New Jersey Turnpike, okay? All right, let me see if there's anything else. I'm not too concerned about the, the different tissue layers of the bladder, just the major components of it, the detrusor muscle, the openings for the ureters, the trigone, the neck, and then in the males where the prostate gland is. I will say this, that, and again, after about, you start to maybe get uncomfortable after about 500, maybe to 600 milliliters of urine start to collect in the bladder, start to put pressure, then you begin to experience the sensation of urgency, okay? What else? Oh, in females, now their urethras obviously are shorter than males because the urethra extends into the external genitalia in the male. And so women have a tendency to develop more cystitis, which is inflammation of the bladder. And for obvious reasons, because the vaginal vault not only has bacteria in it, but it also has yeast in it. And because you have this short urethra, this short connection between the urethral opening and the bladder, bacteria can migrate up there. You've heard of or maybe you've heard of a condition known as honeymoon cystitis?
No.
Well, honeymoon cystitis is usually will follow an extended period of sexual activity, which, in theory occurs during the honeymoon. And because there's so much invasion of the vaginal vault and disturbance of the bacteria and what have you therein, some bacteria can get up into the bladder and cause an infection. Some women are more prone to it than others, my wife in particular. But that is all due to the fact that they're
treated with antibiotics?
treated with antibiotics, yeah. Yeah, what they'll usually do and what they should do, I wouldn't say usually, but what they should do is take a urine specimen, culture out the urine, and see what particular bacteria is growing, and then be specific in the prescribing of antibiotics. However, what usually occurs is, okay, yeah, it sounds like you got a nice bladder infection, we're just going to prescribe a broad spectrum antibiotic. We don't want to go through the whole culture and sensitivity thing. We don't want to grow out the bacteria, see what it is, or try to identify it, and then select a specific antibiotic to treat that particular bacteria, which is, they used to do that. They don't do it so much anymore because it's just like, all right, let's just give them some big guns and see if it works. And if it doesn't, then we'll prescribe some more or a different kind. That's just, I'm not going to get into a discussion about modern medicine, but it's changing. Okay. Anything else we want to? Oh, what I would like you to look at, and I got to get going in a little bit, is table 17.3. I want you just to briefly review that on page 538. It's the function of the different components of the nephron. You'll see the glomerulus, the capsule, the tubules, and it'll break it down to the distal, the descending loop of Henle, the ascending loop of Henle, and then the distal convoluted tubule. Just make a note of those substances that are secreted and or reabsorbed in those particular structures. Since this brings it up, I will bring it up. ADH, we mentioned this a couple of chapters ago, anti-diuretic hormone, produced by the posterior pituitary. Anti-diuretic hormone. Okay, and there's reference made to it. And what this hormone does, it's designed to conserve water. A diuretic makes you pee, so an anti-diuretic isn't going to make you not pee, conserve water. And this hormone will work on primarily the collecting ducts, but I believe there is some action in the convoluted tubules. It says the distal convoluted tubule, and makes them less permeable to water, so that when the filtrate travels through there, the water will not be reabsorbed. Okay, so it will dilute the urine. It will concentrate the urine when it's released. Okay, conserve water. All right, and again, it's where it works, primarily in the collecting ducts and the distal convoluted tubule. Now, there is a substance out there, much to my chagrin, called ethyl alcohol, or ethanol, and a certain blood level of ethanol will inhibit the release of ADH from the pituitary gland, so you won't conserve water, and so that the collecting ducts and distal tubules will remain very permeable to water. And you'll notice if you go to a bar and you throw down 3 or 4 beers, after a while you have to get up and you have to use the restroom. And then you have to keep going back and use the restroom, especially if you keep pounding down the beers. All right, so alcohol suppresses ADH, or suppresses the release of ADH. Okay, so then these collecting ducts and distal tubules are not conserving water, which helps to explain why maybe the next morning when you wake up, especially if you've consumed ethyl alcohol to excess, you may have a headache because your blood volume's down a little bit because you've been peeing most of the night. Your mouth is all dry and cracked and feels like an army went and marched through it. So, moderation, the key to living. Everything in moderation. All right, let me just kind of scan back through here and see if there's anything else. All right, it says glucose, proteins, ketones, and blood cells are not usually found in the urine. That's this table right here. Okay, which on page 538. These unusual urinary components may reflect certain normal conditions or disease. For example, glucose in the urine may follow a large intake of carbohydrates. If you've eaten a lot of carbohydrate in your diet, you're getting ready to deliver a baby, or due to diabetes mellitus, which we already mentioned. And so people who are predisposed to diabetes, should not only check their blood sugar, but every so often check the urine. Okay. Anything else that we want to talk about? Tubular secretion. Yeah, and I don't get real picky about a lot of the things that are secreted and a lot of the things that are reabsorbed, but if you keep in mind, like, the big picture, what does your body need? It needs water. It needs sugar, okay? It needs sodium, okay? Chloride, all right? Now, and again, in helping to maintain blood pH, it can regulate whether it will get rid of hydrogen ions or reabsorb hydrogen ions to maintain our 7.35, which I want you to remember that, 7.35 to 7.45 blood pH. Okay? Other than that, to get real picky on that is fine if you're going to, do some research and do some work in nephrology. But for our purposes, as long as you're aware of the big picture of that this tubular secretion and tubular reabsorption processes that occur in the renal tubules sort of fine-tune. What does the body need? What do we need to get rid of? That's where it happens. Okay? All right. Oh, one other, and I think I do remember seeing something about this gout, if you've ever heard of that. Have you ever heard of that?
Yes, I have.
You have. You don't have it, do you?
No.
Thank you. But gout, or gouty arthritis, results from a collection of, if you have excess uric acid in the blood, gets deposited, uric acid, and it forms these crystal-like formations, uric acid crystals. And some of the more common places where they're deposited include the joints of the finger or the hands, in joints. And one of the classic places where gout seems to be a problem is the great toe, the big toe. But also in the joints of the digits, your fingers. Okay, and so what do they do about that? Well, they prescribe drugs to help interfere with the normal metabolism of nucleic acids, DNA and RNA. We're all the time, people, we don't think
Isn't gout not very prevalent today?
I'd have to check the stats on that. I don't know. I know back in my day there is a drug it always sticks in my mind. It's called allopurinol. And this was one of the mainstays for the treatment of gout. I don't know if they still do that, and I really don't know what the incidence is in the general population. But I know it's still out there because one of the guys I used to work with, was a big fella, had gout, and I know it's painful. All right. Excess uric acid may precipitate in the plasma and be deposited as crystals in joints, called gout or gouty arthritis. It says here, King Charles I of Spain gave up his vast empire in 1556 due to gout. How about that? All right, sodium water reabsorption. All right, just let me make a note of this and then I gotta quit. On figure 1711, okay? And what that will do, we've already sort of addressed it, but if you look at that particular figure on page 533, you'll see what provides for the 1711 on 533, yeah. You'll see what provides for the filtration. Okay, you have different pressures involved. Okay, you can see the first component of this filtration process is blood pressure, blood flow, what they call blood hydrostatic pressure, or we call it BHOP, BHP, blood hydrostatic pressure. All right, and that favors the movement of the material out of the blood through the capillaries into Bowman's capsule. Now you have some other pressures that are involved. You see this blood colloidal osmotic pressure, which favors the movement of material out of blood, and that favors the movement of material into the blood. Okay, a colloid, because by osmosis, water will move from an area of high water to an area of low water. And wherever you have a lot of colloids or a lot of things like proteins, obviously you have less water. So if there's more water outside of the blood than there is inside, then the water will move into the blood because of this blood colloidal osmotic pressure. You also have capsular hydrostatic pressure, CHP, and that will favor the movement back into the blood because it's, you have this capsule with this capillary network, and here's the capsule. All right, so if there's fluid in this capsule and the pressure of that fluid is greater than it is in the blood, then it's going to push material back into the blood. All right, so you have capsular hydrostatic pressure favors movement of material back into the blood. And so what you have to do, and then you have, is add these three up, or account for all three of these. In general, under normal circumstances, BHP, blood hydrostatic pressure, will outdo, I don't know if they give us any general
60
numbers.
millimeters.
All right, 60 millimeters of mercury. So we'll say 60 millimeters of mercury pressure. All right, what's the BCOP?
Minus 32.
All right, and they say minus because it's to sort of signify a negative pressure. In other words, this pressure is working to push material out. And then there's a pressure on the other side of that capillary that's working to, move material back into the blood, okay? So we have this is a minus
32.
minus 32 millimeters of mercury, and then the blood
Is minus 18.
minus 18. So,
Gives you a net of 10.
yeah, so if you add these two negatives up, you have a 40. Gives you a net of 10. 60, 32, and 18. We didn't account for one. It shouldn't be 10 though, it should be 20.
No, it's 50. 50 and 60. It's 32 and 18 or
It's 50, I'm sorry, my bad. Yeah, 50. So you have this negative pressure of 50, which is favoring the movement of material back into the blood, and you have this pressure of 60, which is favoring the movement of material out of the blood, so the net filtration pressure will be 10 millimeters of mercury out. In other words, favoring the pushing of material out of the blood into this capsule here, okay? And we saw, I don't know if you remember or not, but we saw similar forces in play when we were talking about the circulatory system and the venous end of a capillary bed and the arterial end of a capillary bed. At the arterial end of a capillary bed, blood hydrostatic pressure was high, and then the interstitial fluid osmotic pressure you had to take into account. And so at the arterial end, when we added up the numbers, it favored movement of material out of the arterial end and into the interstitial fluid. And then at the venous end of the capillary, because the colloidal osmotic pressure was higher than the blood pressure, then it favored movement of material back into the blood. Okay? All right. So this was just to sort of put some numbers, some values to it to say, well, why does filtration happen? Okay, filtration, in the grand scheme, and I remember seeing this as a question that some people got wrong, when we talk about these transport processes in the blood, those that are passive and then those that are active, well, active transport processes require energy in the form of ATP. Passive transport processes like diffusion, osmosis, facilitated diffusion, and filtration, they don't require any cellular energy. The energy for filtration is provided for just by blood pressure, BHP, blood hydrostatic pressure. Okay, so it is more or less a passive process provided for by blood pressure. Now you can imagine what happens if your blood pressure drops. What happens to the urine formation?
It probably slows down.
It goes down. So, low blood pressure is nicht gut. And like if you're lying on a gurney with a gunshot wound and you're bleeding out, well, your urine formation starts to go down. All right, and so then what the urine is designed to get rid of stays in the blood. Okay, so that's bad. So we gotta bring blood pressure back up to restore blood hydrostatic pressure and keep this filtration process as normal as possible so that we don't get sick and die from our own poison. Okay. It says right here, if arterial blood pressure plummets as can occur during shock, glomerular hydrostatic pressure may fall below that level, fall below this net 10 required for filtration. All right, so as a result, tubular cells may die. So you don't want to have that low blood pressure for too long, or your kidney cells are going to start to die and you're going to go into kidney failure. And that kind of kidney failure, you're not going to recover from. All right, and sort of in a nutshell, that's what we're talking about.
Turn it on.
And I think, I feel fairly confident that